Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text. Hello and welcome back to the deep dive. Today we're strapping in for something that honestly feels a bit less like a medical textbook and, I don't know, a bit more like the script of a sci-fi movie.
Yeah, it really does sound futuristic when you frame it that way. We're talking about gene editing, factor-produced cells.
Reprogramming the human body to hunt down enemies. It's crazy.
It is. But for the patients living through it, and obviously the nurses caring for them, it's very much the reality of modern medicine. We are talking about the immune system today.
Right. That complex defense force inside all of us.
Exactly. That complex force.
And usually, it works quietly in the background, right?
Mm-hmm.
Just handling business. You get a cut, it heals, you get a bug, you fight it off.
Usually, yes.
But sometimes it needs a boost, or sometimes it needs to be redirected. And sometimes, specifically in the case of cancer, we literally have to re-engineer it to get the job done.
Which brings us to our exact topic for today. And I should mention, this is a special edition of the Deep Dive. It's what we like to call a last-minute lecture.
Yes. We are speaking directly to you, the nursing students out there who might be staring down a pharmacology exam on Chapter 37 right now.
I can almost feel the stress radiating through the audio right now. Chapter 37, Biologic Response Modifiers, or BRMs for short.
It's a dense chapter.
Oh, there is no getting around that. It is incredibly dense.
So the goal here is survival. We want to help you survive that exam by breaking down this chapter from Pharmacology, a patient-centered nursing process approach, the 12th edition.
And because this is a last-minute lecture specifically designed for your course, we have to set some ground rules before we start.
Ground rules are key.
We were sticking strictly to the textbook.
Strict adherence, guys. I know you maybe read an article on Twitter about a new trial or, your aunt's neighbor is taking something experimental in Mexico.
We are ignoring all of that.
Yeah, blocking it out. No off-label uses today. No experimental protocols from last week's news, just the facts as presented in Chapter 37.
We want to make sure what you hear today aligns perfectly with what you are going to see on that test paper.
Precisely. We are building a fortress of knowledge based solely on your required reading. So, where are we headed? What's the roadmap?
Well, first, we are going to do an overview of what on earth a biologic response modifier actually is. We need to wrap our heads around the tech behind it, like recombinant DNA.
Which sounds terrifying, but is actually brilliant.
It really is. Then we are getting into the heavy hitters. We will talk about CAR T-cell therapy.
Oh, which is some of the most fascinating technology in oncology right now. Truly wild stuff.
Then we will break down the interferons, alpha, beta, gamma.
It sounds like a fraternity, but it's actually a family of cytokines.
Right. And after that, we will move on to the colony-stimulating factors, which I know you like to call the rescue squad for blood counts.
I do. A very apt description, I think. They really do come to the rescue after chemo. Then we have interleukins and the terrifying-sounding capillary leak syndrome.
Just the name gives you the shivers, doesn't it?
It really does. And finally, we will wrap it all up with the nursing process: assessment, administration, and keeping the patient safe.
It sounds like a full agenda.
It is. So, grab your highlighter or just turn up the volume. Let's dive right in. Part 1, the overview. What exactly are we talking about when we say biologic response modifiers?
So biologic response modifiers, or BRMs, as you'll see them written, are a class of pharmacologic drugs. You will also hear them called immunomodulators.
Okay.
The core idea is right there in the name. They modify the body's biologic response. Specifically, they are used to enhance, direct, or restore the body's immune system.
Let's pause there for a second because I want to make sure I get the distinction clear for the exam. When we talk about traditional chemotherapy, I usually picture a bomb.
A bomb, okay.
Yeah, like we drop a bomb on the body, hoping it kills the cancer faster than it kills the patient. It attacks anything that grows fast, right? Hair, the gut lining, the tumor. Is this different?
It is very different. Think of traditional chemotherapy as carpet bombing, like you said. BRMs are more like, they're like hiring a special consultant to retrain the local police force.
Oh, I like that.
Or sometimes bringing in a SWAT team that has very specific targeted orders.
Okay, so we aren't just poisoning the bad guys. We are actively empowering the good guys.
In many cases, yes. The text distinguishes between two main approaches here. You have direct therapy, where the BRM targets the cancer cells directly to stop them from growing.
And the second?
Indirect therapy.
Which is stimulating the immune system generally, right? Not necessarily tagging the cancer cell itself, just waking up the whole system.
Correct. It's like raising the terror alert level for the whole country versus sending a specific detective to a specific address. Both are effective, just different mechanisms.
That makes a lot of sense. Now, the text outlines 5 specific functions, ways that BRMs assist the immune system. I feel like this is a list you should probably mentally highlight because it sounds exactly like a select all that apply question waiting to happen.
Oh, it absolutely is a class of nursing exam question. Let's walk through all 5 carefully.
All right, hit me. Number 1.
Number 1 is immunomodulation. That's enhancing the immune system's ability to kill abnormal cells. That's the general boost we just talked about. It makes your natural killer cells more aggressive.
Got it. Making the soldiers fight harder. Number 2.
Number 2 is changing cancer cells to make them behave more like healthy cells.
Wait, hold on. We can actually do that. We could just tell a cancer cell, hey, stop acting crazy and go back to work.
To an extent, yes, we can. Some BRMs interfere with the signaling pathways that make the cancer cell replicate uncontrollably.
That's fascinating.
It's like rehabilitating the cell rather than just executing it. You're altering its biology so it stops being malignant.
Wow. Okay, number 3.
Inhibiting normal cells from changing into cancer cells in the first place. This is the prevention angle.
Stopping the radicalization before it happens. I like it. Number 4.
Enhancing the body's ability to repair or replace damaged cells that were caused by other cancer treatments.
So this is where the rescue idea comes in. If the carpet-bombing chemo wipes you out, the BRMs help you rebuild the walls.
Exactly. This is a crucial concept for nurses to grasp because often it's the side effects of the chemotherapy that kill the patient, not just the cancer itself.
Because they get an infection?
Yeah.
Or bleed out?
Right. So if we can repair the damage to the bone marrow, we can keep fighting the cancer safely. And finally, number 5, preventing metastasis.
Stopping the spread.
Yes, stopping the cancer cells from packing up and setting up shop in other parts of the body.
So they are doing a ton of heavy lifting. But here's the part that always confuses me when I look at biologicals. How do we actually make these drugs? I mean, we aren't mixing chemicals in a beaker for this, are we? Because these are biological proteins.
No, we definitely aren't mixing powders in a lab. The text highlights 2 key technologies that allow for mass production, and this is where that sci-fi element you mentioned really kicks in.
Okay, break it down for us.
The first is recombinant DNA.
I remember this vague term from high school biology. This is genetic engineering, right?
It is, and the text describes it essentially as the process of combining 2 DNA strands artificially. But let's look at what that actually entails because the mechanism is amazing.
Please do.
Imagine you want to make a specific protein, let's say a human interferon. You can't just synthesize it easily with chemistry. So you find the exact gene in human DNA that codes for that interferon.
The blueprint.
Yes, the blueprint. You cut that specific gene out. Then you take a common bacterium, usually E. coli.
E. coli, like the stomach bug that causes food poisoning.
The very same.
Yeah.
You take a plasmid out of the bacteria. A plasmid is just a little circular ring of DNA. You cut that circle open and you paste the human interferon gene right into it.
Okay.
Then you put that new recombinant plasmid back into the bacterium.
So now this single bacteria has human instructions inside it.
Exactly. And because bacteria love nothing more than to divide and replicate rapidly, every time that E. coli bacterium splits, it copies that new human instruction.
Oh.
Within days, you have billions of bacteria, and they are all acting like little microscopic factories, churning out pure human interferon.
That is wild to me. We are literally hijacking the reproductive cycle of bacteria to print medicine for us.
It completely revolutionized pharmacology.
Yeah.
Before this technology, we had to harvest these proteins from animal organs or human cadavers.
Which sounds inefficient.
Yeah.
A little gross.
Very inefficient, very expensive, and dangerous regarding contamination. Now we just have bacterial factories doing the work cleanly and infinitely.
Science is cool. All right, what's the second tech mentioned in the chapter?
Hybridoma technology.
Hybridoma. Sounds like a car model from the 90s.
It kind of does, but it's used for making monoclonal antibodies. This involves engineering cells to produce specific antibodies. You take a cancer cell, which, biologically speaking, lives forever. It's immortal.
Right, because it never stops dividing.
And you fuse it with an immune cell, a B cell that makes a specific antibody you want. You get a hybrid, a hybridoma.
Oh, I see.
It has the endless longevity of the cancer cell, but the helpful targeted production of the immune cell.
So it's an immortal antibody factory.
Correct. Now, the text does note that while monoclonal antibodies are technically BRMs, they are often grouped and considered targeted therapies, which are covered extensively in Chapter 36.
Got it. So we don't need to stress too much about the specific monoclonal drugs today.
Right. But for this chapter, just know that hybridoma technology is a vital part of the family tree of how we make these biologics.
Okay, so we have these incredibly powerful drugs. We are boosting the immune system. We are rehabilitating cells. But there is a huge irony mentioned in the text that I think trips a lot of students up on exams. It feels like a trick question.
Ah, yes, the contradiction.
Right. We are giving these drugs to boost the immune response against cancer. But the text says quite clearly, quote, like chemotherapy, BRMs suppress the immune system, end quote. How does that make sense? We are boosting it to suppress it.
It is entirely counterintuitive at first glance. Think of it this way. We are heavily manipulating the immune system. We might be hyperstimulating one very specific part of it, like the T cells, to fight the tumor.
Okay.
But in doing so, or as a direct side effect of that intense stimulation, the broader generalized immune defense can get exhausted, disrupted, or collateralized. Or sometimes the drug targets any rapidly dividing cells, which naturally includes our own immune cells.
So even though I'm taking an quote-unquote immunomodulator, I might actually end up severely immunocompromised.
Yes. That is the critical nursing takeaway. Patients on BRMs can and do end up in an immunocompromised state. This means they are at significant risk for complications, primarily severe infection.
So just because your patient is on an immune booster doesn't mean they are Superman. They are actually incredibly vulnerable.
Very vulnerable. In fact, the text lists specific contraindications based on this. You should not be giving BRMs to patients with active infection.
Because their body just can't handle the stress of the drug plus fighting the infection.
Exactly. It's too much metabolic demand on the system. They are also contraindicated in severe immunodeficiency syndromes and, interestingly, in demyelinating diseases like multiple sclerosis.
Though there are exceptions to that MS rule, which we will get to later.
Yes, very specific exceptions in the interferon family.
Okay, so that's the general overview. Powerful tools, complex production via bacterial hijacking, and a double-edged sword regarding patient immunity. Now, let's zoom in on one of the newest and honestly most complex therapies mentioned in Chapter 37, CAR T-cell therapy.
This is a massive area of focus in modern oncology. CAR stands for chimeric antigen receptor.
Chimeric, I love that word. It makes me think of the chimera from Greek mythology. You know, the monster that was part lion, part goat, part snake.
The name is actually very fitting because the therapy creates a literal hybrid cell. It's a mix of the patient's own native biology and heavy laboratory engineering. CAR T-cell therapy is a form of immunotherapy that is incredibly sophisticated and completely individualized.
So this isn't just taking a pill from a bottle, right? I can't go to the hospital pharmacy and just pick up a bag of QRT.
No, not at all. We are manufacturing a drug specifically for one single person using their own living cells as the raw material. It's the ultimate bespoke medicine.
Walk us through the process exactly as described in the text. Let's say I'm the patient. I have leukemia. What happens to me?
Step 1, you go to a specialized treatment center. We connect you to a machine and perform a process called leukapheresis. We are basically filtering your blood to remove your T cells.
And T cells are the soldiers of the immune system.
Yes. So we take your army out of the country, we bag them up and send them to a highly specialized lab.
And what happens in the lab? Boot camp.
Essentially, yes. But a genetic boot camp. They are genetically modified. Scientists use a viral vector to insert a new gene into your T cells. That gene programs the cells to grow a brand new receptor on their surface.
And these are the chimeric antigen receptors, the CARs.
Precisely.
So they are giving the soldiers new weapons? Or is it more like giving them night vision goggles?
It's exactly like giving them a homing beacon or night vision goggles. These CARs are specifically designed to recognize and bind to specific antigens that are only found on the surface of your specific cancer cells.
Wow. So before this, my T cells were just walking right past the cancer, completely ignoring it, not seeing it as a threat. But now they have a detector that beeps when they get close.
Exactly. The cancer was hiding in plain sight. Now it can't. Once the cells are modified, they are allowed to multiply in the lab until there are millions and millions of them. Then they are frozen, shipped back to your hospital, and infused back into your bloodstream.
So you take the T cells out, give them a target profile for the cancer, multiply them, and put them back in to hunt.
And once they are back in, they bind to those cancer cells and absolutely destroy them. Plus, because they are living cells, they continue to multiply inside the body. They become a living, breathing drug.
That is incredible. Now, the text mentions some specific approvals for this. It's not a first-line treatment for everyone, right? I can't get this for early-stage stuff.
No. The FDA approvals mentioned in the text include acute lymphoblastic leukemia, specifically in children and young adults, and diffuse large B-cell lymphoma in adults. It also mentions approvals for certain other lymphomas and multiple myelomas.
And looking at table 37.1 in the text, where it lists the specific drugs, these generic drug names are, well, they are a nightmare to pronounce.
They really are. They are a mouthful.
I'm going to try one just so we hear it. Tizigin-Laclucel.
You got it. Perfect.
And axicabtagene-silousel.
Very good.
Why do they do this to us? Why so many syllables for nursing students to memorize?
It's an international naming convention based on the viral vectors and cell types. But for the students listening right now, do not panic about the exact spelling. You don't need to win a spelling bee. Focus on the recognition.
What's the clue they should look for?
Notice the suffix "lucel" at the end of all of these. Tizidin-lucel. Axicabtagene-silousel. Lucel sounds like leukocyte or cell.
Oh, that's smart.
That is your immediate clue on a multiple choice test that you're dealing with a cellular therapy, specifically a CAR-R T cell.
That is a great tip. Lucel equals cell therapy. Write that down.
Right. And you should also note the indications. These are generally used when other conventional treatments have completely failed. This is the Hail Mary pass in oncology.
Right. The text says specifically, quote, used after other conventional treatments failed. This is the heavy artillery when nothing else is working.
And because it's the heaviest artillery we have, the collateral damage can be massive. We need to talk about the dangers.
Let's look at the adverse effects section. There's a big one here. CRS.
Cytokine release syndrome. If you remember absolutely nothing else about CAR T-cell therapy from this deep dive, you must remember CRS.
What is happening physiologically during CRS?
When these millions of supercharged T cells find the cancer, they attack it all at once. It becomes a massive microscopic war zone inside the patient. And like any war zone, there is debris and frantic signaling. The T cells release massive amounts of cytokines, which are inflammatory messengers, into the bloodstream simultaneously.
That's like a chemical storm.
It is exactly that. It's often referred to clinically as a cytokine storm. And the symptoms reflect that intense systemic shock. High fever, we're talking 104, 105 degrees Fahrenheit. Dyspnea, which is severe difficulty breathing. Tachycardia, a dangerously racing heart. And severe GI disturbances like uncontrollable nausea and vomiting.
It sounds like the worst flu of your life combined with a heart attack.
And it can absolutely be fatal. There is a strict black box warning explicitly for cytokine release syndrome. It creates a systemic inflammatory response that can lead to rapid multi-organ failure. The kidneys shut down, the lungs fill with fluid, the blood pressure bottoms out.
And there's another toxicity mentioned right next to it in that black box warning, neurotoxicity.
Right. This is even more mysterious and frightening. We see profound changes in the brain.
What did that look like at the bedside?
Changes in the level of consciousness. Seizures. Dysphagia, which means profound difficulty speaking or finding words. Confusion. A patient might be sitting there talking to you clearly 1 minute, and the next minute they literally can't remember their own name or they can't form a basic sentence.
That is terrifying, especially for the family sitting in the room to watch.
It is incredibly traumatic. So as a nurse, if my patient is receiving CAR T-cell therapy, I am watching them like a hawk. I'm not just checking if they're comfortable. I'm constantly doing neurochecks. Can they speak clearly? Can they squeeze my hands? Is their temperature spiking even half a degree? Are they breathing okay?
The text also notes that these therapies often have, quote, restricted distribution because of these severe risks.
Yes. You usually only see these administered in specialized tertiary cancer centers that have a dedicated ICU ready to go at a moment's notice. You have to be specially certified to even administer these drugs because you need to know exactly how to rescue the patient from these severe side effects instantly.
Okay, that is CAR T-cell therapy. Heavy stuff. Let's move from the cutting-edge customized cells to one of the older but still very important families of BRMs, the interferons.
Interferons, or IFNs as they are abbreviated, these are naturally occurring cytokines in the body. We actually make them every single day.
The word interferon sounds exactly like interfere. Is that too literal of a way to remember it?
Not at all. That is exactly what they do. They were originally named because scientists observed that they quote-unquote interfere with viral replication.
I love when scientists keep the naming simple. It really helps.
Ideally, your body produces them naturally when a virus attacks. But in the context of cancer and pharmacology, we synthesize them and give them as drugs to work directly on cancer cells. They slow the tumor growth, or as we said in the 5 functions earlier, they force the cancer cells to behave more like normal differentiated cells.
The text divides them into type I and type 2. What's the breakdown there?
It's fairly straightforward. Type I includes interferon alpha and interferon beta. Type 2 includes interferon gamma.
Okay, let's start with the big prototype mention for type 1, interferon alpha. Specifically, the text highlights IFN alpha 2b.
Interferon alpha is really the workhorse of the interferon family. Naturally, it's produced by our B cells and macrophages. Its clinical indications are quite broad. The text lists hairy cell leukemia, Kaposi sarcoma, which you might know is an AIDS-related cancer malignant melanoma, and non-Hodgkin's lymphoma.
And it's not just for cancer, right? Since its original job is interfering with viruses.
Correct. It has very strong antiviral properties, so you will also see it used for hepatitis B and hepatitis C, as well as human papillomavirus, or HPV.
How is it usually administered to the patient?
Parenterally. That means for CM, IM intramuscular or subcut, subcutaneous. You can't take it as a pill. The stomach acid would instantly destroy the protein before it could do anything. And pharmacokinetically, it is catabolized or broken down by the kidneys.
Now let's talk about the patient experience, the side effects. If I'm taking interferon alpha, how am I going to feel on a daily basis?
You are going to feel terrible.
Just the honest truth.
It is. You will feel exactly like you have a severe case of the flu.
Literally the flu.
Yes. The text explicitly describes a, quote, flu-like syndrome. Extreme fatigue, loss of appetite, chills, high fever, and severe myalgia, which is muscle pain.
Why does that happen? Is it an allergic reaction?
No, it's actually the drug doing exactly what it's supposed to do. Think about when you actually catch the influenza virus. The reason you feel achy and feverish isn't really the virus itself doing that to your tissues. It's your own immune system releasing massive amounts of natural interferon to fight the virus.
Oh, wow.
So when we inject synthetic interferon as a drug, we are chemically recreating that exact sick feeling. The body thinks it's fighting a massive infection.
Is this a rare side effect?
No, it is extremely common. The text says these side effects are, quote, not usually severe in terms of lethality, but patients will universally report these symptoms. It drastically affects their quality of life. Nurses need to proactively warn patients. You have to tell them, you are going to feel achy, you're going to run a fever, this is expected.
However, we had to distinguish between those common, expected side effects and the genuinely dangerous ones, because there is a black box warning for interferon alpha too.
Yes, there is. Interferon alpha carries a severe black box warning for fatal or life-threatening neuropsychiatric, autoimmune, ischemic, and infectious disorders.
Let's unpack that first word, neuropsychiatric. That sounds very serious.
It is incredibly serious. We are talking about severe clinical depression and active suicidal ideation.
Wait, a cancer and hepatitis drug can literally make you suicidal?
Yes. It fundamentally alters brain chemistry and neurotransmitter function. The text mentions that if a patient develops severe depression, the treatment often needs to be stopped immediately, regardless of how well it's fighting the cancer.
That is a huge nursing assessment point then. We aren't just checking their blood pressure and temperature, we are actively checking their mental status. Like, how's your mood today? Are you feeling hopeless?
Exactly. You cannot ignore the psychological assessment with interferon patients. It is life or death. You also need to continuously monitor the heart, that's the ischemic disorders part of the warning, and watch for new opportunistic infections. Because remember, the overall immune system is getting distracted and suppressed.
Are there any specific drug interactions we should flag for the exam?
The text specifically highlights an interaction with theophylline.
The respiratory drug.
Yeah.
For asthma and COPD.
Yes. If you take interferon alpha concurrently with theophylline, the interferon drastically slows down the liver's ability to process and clear the theophylline. It can increase theophylline levels in the blood by up to 100%.
Wow, so it essentially doubles the patient's dose without them taking an extra pill. That could quickly become toxic.
Right. It leads to theophylline toxicity, which causes dangerous arrhythmias and seizures. So use extreme caution with anything metabolized by the liver, specifically drugs relying on the cytochrome P450 system.
Okay, that's alpha. What about interferon beta?
Interferon beta has a very specific, narrow focus in this chapter. It is primarily used for multiple sclerosis, or MS.
Now that brings us back to that contraindication we talked about earlier. We said generally BRMs are avoided in patients with demyelinating diseases like MS, but beta is the exception.
Beta is the exact treatment, specifically the drugs IFN beta 1A and IFN beta 1B.
How does it work to help MS?
MS is a devastating autoimmune disease where the body's own immune system attacks the myelin sheath, the protective insulation around the nerves. Interferon beta works by inhibiting the specific pro-inflammatory cytokines that trigger that attack. It acts like a targeted fire extinguisher for that specific inflammation.
Okay, so it calms the attack down.
It also reduces the migration of T cells across the blood-brain barrier. It literally stops the aggressive immune soldiers from getting into the brain and spinal cord to chew up the nerve sheaths.
And the text mentioned something about it actually helping with repair.
Yes, it has been shown to increase nerve growth factor, which might actively help with remyelination, repairing the damage that was already done.
That's amazing. And finally, interferon gamma.
Type 2. This is primarily an immune regulator. Its main job is to activate macrophages, the big eater cells of the immune system, making them highly aggressive to kill parasites and cancer cells. Clinically, it's used for chronic granulomatous disease and osteopetrosis.
Osteopetrosis, that's the rare bone disease, right? Where the bones become overly dense.
Yes, sometimes called stone bone disease. Interferon gamma helps regulate the dysfunctional immune response in those specific rare genetic conditions.
Okay, so we have the interferons, quote-unquote, interfering with viruses and cancer and regulating autoimmune issues. Now let's move to a group of drugs that I genuinely think are the unsung heroes of the oncology ward. The colony-stimulating factors, or CSF?
Ah, yes. The rescue squad.
Right. Because let's be real for a minute. Chemotherapy is brutal. It's essentially systemic nuclear warfare on the body. It's designed to kill fast-growing cells. But what naturally grows fast, besides cancer?
Bone marrow cells, the cells that constantly manufacture your blood, your hair follicles, your GI tract lining.
Exactly. So chemo nukes the bone marrow. The patient ends up with no red blood cells, so they are severely anemic. They have no white blood cells, so they have severe neutropenia.
Right.
And they have no platelets, causing thrombocytopenia. This whole state is called myelosuppression.
And myelosuppression is incredibly dangerous. If you have no white blood cells, a common cold, or even the normal bacteria on your own skin can cause a fatal sepsis. If you have no platelets, you can literally bleed to death from a minor bump or a paper cut.
And that is exactly where CSFs come in. They don't kill the tumor directly, they fix the blood factory. The text lists 3 main clinical benefits of using CSFs.
Benefit number 1, they decrease the length of post-treatment neutropenia. This means the dangerous window of time where the patient is vulnerable to infection is significantly shortened. Instead of being defenseless for 2 or 3 weeks, maybe it's only 3 to 5 days.
That's a huge difference in survival rates. Benefit 2.
They permit the delivery of higher, more tumoricidal doses of chemotherapy.
Walk us through that one.
Well, often oncologists have to prematurely stop chemo or lower the dose because the patient's blood counts drop too low to survive. It's called dose-limiting toxicity. The doctor says, I really want to hit this tumor hard, but if I do, I'll permanently destroy the patient's marrow.
But if we have CSFs available,
we can confidently give that massive high dose of chemo, knowing we have the CSFs ready to rescue and rebuild the bone marrow immediately afterward. We can hit the cancer much harder without killing the patient.
That makes total sense. And benefit 3.
Reduce bone marrow recovery time after a bone marrow transplant. It helps the newly transplanted marrow, quote-unquote, take and start producing blood cells faster.
Okay, let's look at the specific drugs in this category. The text breaks them down by what specific line of blood cells they stimulate. First up, erythropoietin-stimulating agents, or ESAs.
The classic prototype drug here is epoetin alpha. You might also see darbepoetin alpha on an exam.
Epoetin? It sounds exactly like erythrocyte, which is a red blood cell.
Exactly. It's a great naming cue. They work exactly like the natural hormone erythropoietin, which is normally manufactured by your kidneys. They stimulate the bone marrow to produce red blood cells, a process called erythropoiesis.
So these drugs are purely for anemia?
Yes. They increase hemoglobin levels and restore oxygen carrying capacity. If a patient is pale, lethargic, and short of breath just walking to the bathroom from chemo-induced anemia, this is the drug that gives them their energy back.
Now, stop everything. If you are listening to this while driving or making dinner, listen very closely right now. This is probably the single most critical safety alert in the entire chapter. There is a very strict, unforgiving rule about when not to give this drug.
You are absolutely right. This is a black box warning, and it is a guaranteed exam concept. ESAs drastically increase the risk of death, myocardial infarction, which is a heart attack stroke, and active tumor progression if the patient's targeted hemoglobin is greater than 11 grams per deciliter.
11. That is the magic number. Write 11 on your hand before you walk into the test.
Yes. If a patient's hemoglobin is above 11 GDL, you absolutely do not give this drug. In fact, if the hemoglobin rises more than 1 GDL in a 2-week period, you have to drastically modify the dosage or stop it entirely.
Why? What is actually happening in the body if it goes over 11?
Think about what red blood cells physically do. They make the blood thicker. It increases viscosity. If you artificially pump too many red cells into the cardiovascular system too fast, the blood literally turns into a thick sludge.
And sludge doesn't flow well through tiny capillaries.
No, it doesn't flow. It clots. It causes massive thrombosis. And those clots travel to the brain, causing strokes, or the heart, causing fatal MIs.
And curiously, the text says it can actually cause tumor progression. That seems completely counterproductive for a cancer patient.
Yes, studies have shown that some tumors seem to grow faster and more aggressively when ESAs are used to push hemoglobin too high. So the clinical goal is to use the absolute lowest dose possible just to avoid needing blood transfusions. We are not trying to get them back to normal, healthy levels of 13 or 14. We are just trying to keep them out of the danger zone.
So nursing rule number 1 for apoetin alpha. Always check the hemoglobin lab value before administering.
Always. If it's 11.1, you hold the dose, document it, and call the provider immediately. Do not administer it.
Also, the text mentions something specific about iron stores.
Right. You physically cannot build red blood cells without the raw ingredients. Iron is the primary ingredient of hemoglobin. If the patient has low iron stores, giving them apoetin is pointless. It won't work. It's like hiring 1,000 construction workers to build a brick wall but giving them 0 bricks.
So you have to check transferrin and ferritin levels too.
Correct. And often they will need iron supplements concurrently.
Moving on to the second class of CSFs, granulocyte colony stimulating factor, or GCSF.
The prototype drug for this class is filgrastim.
And what exact bloodline does filgrastim stimulate?
Neutrophils, the specific vital type of white blood cell that fights off bacterial infections.
Okay, keeping it straight for the test. Apoetin is for anemia, building red cells. Filgrastim is for neutropenia, building white cells.
Correct. Filgrastim directly helps boost that absolute neutrophil count, or ANC.
Now, there's a variation of this drug listed called pegfilgrastim. It sounds like filgrastim's slightly more complicated cousin.
It is. It's all about the pharmacokinetics and dosing schedule. Standard filgrastim is usually given as a subcutaneous daily injection. Pegfilgrastim is what we call a pegylated version.
What does pegylated actually mean in chemistry?
It means scientists attached a polyethylene glycol molecule to the original drug. This physically makes the drug molecule much larger, which means the kidneys can't filter it out and excrete it as fast. It stays circulating in the body much longer.
So it's basically just the slow-release, extended version.
Exactly. Because it lasts longer, it is administered just once per chemotherapy cycle instead of daily.
That's a huge convenience for the patient. One shot versus, 10 or 14 daily shots.
Absolutely. It drastically improves compliance. But let's talk about the side effects of these GCSFs. What do you think happens when you chemically force the bone marrow to suddenly produce millions and millions of white blood cells overnight?
I imagine the factory gets extremely crowded.
It does. It physically expands. And remember, that factory is located inside the rigid structure of your bones. Bone pain, specifically deep skeletal pain in the long bones like the femur or the sternum or the hips, is a very, very common side effect.
Arthralgia and myalgia.
Yes. Nurses absolutely need to anticipate this. You should tell the patient ahead of time. Your bones might ache deeply over the next few days. Don't panic. That actually means the drug is working to build your immune system back.
Is there anything genuinely dangerous to watch for besides the expected pain?
Splenomegaly, which is an abnormal enlargement of the spleen. The spleen's job is to filter blood cells. If it gets overworked by this massive influx of new white cells, it engorges and gets big. In rare, severe cases, the spleen can stretch so much it can actually rupture.
And a ruptured spleen is a massive internal bleeding event. It's a surgical emergency.
It is. So if a patient on filgrastim suddenly complains of left upper quadrant abdominal pain or radiating shoulder tip pain, you need to investigate that immediately. It's not just a tummy ache.
Okay, good to know. And the third class is CSFs. Granulocyte macrophage colony stimulating factor, GM-CSF.
Prototype drug here is sargramostim.
The name gives it away perfectly. GM, granulocyte, and macrophage.
Exactly. It has a much broader action profile. It stimulates the growth of granulocytes, A and D macrophages. It's typically reserved and used in bone marrow transplants to help the new donated marrow engraft properly and start working across multiple cell lines.
Okay, so that's the rescue squad chapter done. Epoetin for red cells, but watch that hemoglobin do not go over 11. Filgrastim for neutrophils, expect deep bone pain. And sargramostim for the whole myeloid line in transplants.
That is a perfect, concise summary for an exam.
Now we move to part 5, interleukins.
Interleukins are naturally occurring, hormone-like glycoproteins manufactured by our T lymphocytes. Their main biological job is to facilitate complex communication between different immune cells.
The text focuses mainly on aldesleukin, which is also known as interleukin-2 or IL-2.
Right, aldesleukin. Clinically, this is used for very serious cancers, specifically metastatic renal cell carcinoma, which is kidney cancer, and metastatic melanoma, an aggressive skin cancer.
Serious cancers require serious drugs.
Yes, and this is a very serious drug. We need to spend some time talking about its major life-threatening complication, capillary leak syndrome, or CLS.
This sounds absolutely terrifying just from the name. Capillary leak. What is happening physiologically to the patient?
Think of your blood vessels, your capillaries, as pipes. They're supposed to be watertight to keep the blood flowing to the organs. Aldesleukin can cause the endothelial walls of those pipes to lose their vascular tone and become highly permeable. They get incredibly leaky.
So the fluid inside the blood, the plasma, literally just starts seeping out through the walls.
Exactly. The plasma proteins and the intravascular fluid leak out of the blood vessels and dump right into the surrounding tissue, the extravascular space.
So your circulating blood volume just drops off a cliff.
Drastically. Massive hypovolemia. And if your blood volume suddenly drops, what happens to your blood pressure?
It crashes. Severe hypotension.
Massive, profound hypotension. And if your blood pressure drops too low, your vital organs simply don't get blood flow.
Organ perfusion totally fails.
Right. The kidneys stop producing urine and shut down. The heart muscle doesn't get enough oxygen. The brain is starved of oxygen. It can very quickly lead to death.
And meanwhile, all that fluid that leaked out is just sitting in the tissues, so the patient is swelling up like a balloon.
Yes. Severe generalized edema. And worse, acute respiratory distress because the lungs literally fill with that leaked fluid.
Is this a rare 1 in a million side effect or something we really have to watch for?
It is a highly significant risk. The text specifically warns that vascular tone can be lost completely within just 2 to 12 hours of starting the drug infusion.
Because of this risk, where do we give this drug? I assume I can't just give this at a standard outpatient infusion clinic, right?
Absolutely not. The black box warning is abundantly clear. It must be administered only in a specialized hospital setting by a highly experienced clinician. You need immediate resuscitation equipment nearby. You need intensive, continuous cardiovascular monitoring. It is strictly an ICU-level drug.
And box 37.1 in the text lists some absolute contraindications for aldesleukin.
Yes. Because of that massive, sudden fluid shift we just described, patients with existing cardiac disease, pulmonary disease, or renal failure simply cannot take this drug. Their compromised bodies cannot handle the immense hemodynamic stress of capillary leak syndrome. If your heart is already weak, the sudden hypotension from CLS will kill you.
What about drug interactions with aldesleukin? Anything nurses should look out for on the med list?
You must avoid corticosteroids like dexamethasone or prednisone. They entirely negate the therapeutic effect of the interleukin. Remember, you are giving IL-2 to aggressively boost the immune system. Steroids profoundly suppress it, so they completely cancel each other out.
What about blood pressure meds, if they cause hypotension?
You have to be extremely careful with antihypertensives. If the patient is already taking a daily beta blocker or ACE inhibitor, and then they develop capillary leak syndrome, the resulting hypertension will be almost impossible to reverse or manage.
It sounds like an incredibly delicate balance, walking a tightrope.
Very delicate. It requires constant nursing vigilance.
All right, we've thoroughly covered the drugs themselves, the mechanisms, the risks. Now, let's bring it home to the bedside. Part 6. Clinical judgment and the actual nursing process. I'm the nurse working the floor. I have a patient scheduled for a BRM. What am I doing first?
Let's start with assessment, recognizing the cues.
History taking is always first.
Right. A detailed, comprehensive medication history. You absolutely must ask about OTCs, over-the-counter meds, and herbal supplements. As we mentioned with the theophylline example, some of these BRMs interact heavily with liver enzymes. You need to know every single thing they are ingesting.
And what baseline labs am I pulling?
The CBC, the complete blood count, is king here. You need to know the patient's baseline before you alter it. Are they already anemic? Are they already neutropenic? You also strictly need liver and kidney function tests. AST, ALT, BUN, creatinine, because that's how these drugs are ultimately cleared from the body.
And specifically for the ESAs, the epoetin we talked about.
Check their iron and ferritin levels. If those are low, you must ask the provider about prescribing iron supplements before you even bother starting the epoetin.
Okay, moving to interventions. Taking action. We talked a lot about that severe flu-like syndrome with interferons and other BRMs. How do we manage that? Do we just hand them a blanket and tell the patient to suck it up?
Definitely not. We actively treat it. Pre-medication is vital nursing care here. The text strongly suggests pre-medicating the patient with acetaminophen Tylenol to help prevent the severe fever and muscle pain, and diphenhydramine Benadryl to help blunt the histamine effects.
The dose of Tylenol and Benadryl maybe 30 minutes before the infusion.
Exactly. It makes a huge difference in patient compliance. It dampens the body's aggressive reactions so the patient is significantly more comfortable.
What are we actively monitoring during the actual administration?
Continuous vital signs. You are watching like a hawk for that sudden hypotension with IL-2, or extreme tachycardia, which could signal the start of cytokine release syndrome with CAR-T. You also watch the skin for rashes or blistering, and constantly monitor for subtle bleeding risks if their platelets are low.
Safety-wise, anything specific in the room?
Always have emergency resuscitative equipment on standby. Epinephrine, oxygen, the crash cart. Severe anaphylaxis is always a real risk when you are infusing foreign proteins. You need the cart nearby, not down the hall.
And finally, patient teaching. What do I absolutely need to tell my patient before they are discharged to go home?
Tell them to accurately report those flu-like symptoms. While we expect them, we need to know immediately if they escalate or if the fever gets dangerously high.
And swelling.
Yes. Tell them, report any sudden weight gain, like 2 pounds in a day, or visible swelling in your ankles or hands. That could be early edema from a drug-induced heart failure or the insidious start of capillary leak syndrome.
And infection prevention is big, right?
Crucial. Avoid crowds, avoid malls, and strictly avoid people who are sick with infections. Remember the irony we discussed. Even though we are quote-unquote boosting their immune system to fight cancer, the text clearly reminds us they are often severely immunocompromised to daily pathogens.
And there was one very specific note on vaccines in the chapter.
Yes. Patients on BRMs must not receive vaccines containing live viruses. Their modified immune system cannot handle the live attenuated virus safely, and they could actually contract the active disease the vaccine is supposed to prevent.
Excellent point. Okay, part 7. Let's look at the specific case study from the end of the chapter to see if we can actually apply all this theory.
The scenario involves a 75-year-old patient who has metastatic non-small cell lung cancer.
Okay. And it says 2 weeks ago they received a heavy round of chemotherapy, specifically carboplatin and paclitaxel. Now they are admitted to your unit.
Let's look closely at their morning labs. Their hemoglobin, HGB, is 6.9 GDL.
Okay, 6.9 is severely anemic. Normal is usually above 12 or 13, depending on gender. This patient is literally running on empty.
Right. If you assess them, they're probably visibly pale, dizzy when they stand, and exhausted just breathing. And look at their ANC, the absolute neutrophil count. It is 0.096.
Wait. 0.096. That is practically zero.
It is profound, severe neutropenia. This patient has basically zero natural defense against bacteria right now. A simple bacteria naturally living on their own skin could easily enter a tiny scratch and cause a rapidly fatal sepsis.
Exactly. So, in the case study, the patient is prescribed 2 specific BRM drugs to help, filgrastim and epoetin alpha. Let's play the why game. Why the filgrastim?
To aggressively boost the neutrophils, the patient has a massive critical infection risk because the chemo wiped out their marrow. Filgrastim will stimulate the bone marrow to start making more white blood cells immediately.
And why the epoetin?
To fix the critical anemia, the hemoglobin of 6.9. The clinical goal is to raise the hemoglobin slowly so the patient regains oxygenation and ideally doesn't need a whole blood transfusion.
But applying my nursing judgment, what do I strictly monitor while giving the epoetin?
We meticulously monitor that hemoglobin level on the daily CBC. We want it to go up, yes, but not too high. If it hits that magic number of 11, we hold the dose and stop.
And watch for hypertension.
Yes, epoetin can significantly raise blood pressure as the blood volume expands, so you must check the BP immediately before administration.
This case study really beautifully highlights how these supportive drugs are used together clinically to support the patient through toxic chemo. It's not always just about killing the cancer. It's about keeping the patient alive and stable long enough for the chemo to actually work.
It really does. It's the true rescue squad in action at the bedside.
Before we wrap up today's deep dive, let's just hit a few quick review highlights, the fast facts that are highly likely to be multiple choice questions on your exam. I'm going to quiz you. Rapid fire.
I'm ready. Go for it.
Question 1. Which drug strictly stimulates neutrophil production?
Filgrastim, or its long-acting cousin, pegfilgrastim.
Question 2. Which drug stimulates red blood cell production?
Epoetin alpha, which is an ESA.
Question 3. What is the unique specific dosing schedule for pegfilgrastim?
It is given just once per chemotherapy cycle versus the daily injection required for standard filgrastim.
Question 4. Which specific drug causes the deadly capillary leak syndrome?
Aldesleukin, also known as interleukin-2.
Last question. Which drug carries a severe black box warning requiring you to stop if hemoglobin is greater than 11?
Epoetin alpha.
Excellent. Honestly, I feel completely ready for the exam just hearing that summary.
It really just comes down to organizing it in your head. Matching the drug class to the specific blood cell line, it helps, and remembering the one big bad side effect or warning for each category.
So to comprehensively summarize our deep dive today, we have thoroughly covered the immune boosters, the interferons and interleukins that help the body actively fight the cancer directly or indirectly.
And we covered the colony-stimulating factors, the vital support crew that aggressively repairs the blood counts after the chemo bombs them.
These drugs are incredible, powerful allies in modern oncology. But as we've seen with the numerous black box warnings, they are not without very serious risks.
And that is exactly where the nurse's role is critical. The physician prescribes it, but you manage it. You are the one at the bedside monitoring and distinguishing for the patient between the expected flu versus the fatal reaction. You are the one distinguishing between common side effects and the deadly start of cytokine release syndrome or capillary leak syndrome.
That level of vigilance is literally the difference between life and death for these vulnerable patients.
It truly is. Pharmacology isn't just mindlessly memorizing unpronounceable drug names. It's deeply understanding the cellular mechanism so you can accurately anticipate the physical problem before it happens to your patient.
Well said. That brings us to the end of our last-minute lecture on Chapter 37.
We really hope this deep dive helps you crush that pharmacology exam.
And here is a final, maybe slightly provocative thought to take with you as you study. We talked extensively today about how these drugs artificially boost and manipulate the immune system. But think about the natural balance for a second. Think about how the body usually works so hard to keep that immune system strictly in check, so it doesn't accidentally attack its own healthy tissues.
Right, the autoimmune balance.
Exactly. These biologic drugs purposefully override those ancient evolutionary checks and balances. It's a powerful, kind of humbling reminder of how delicate our biological equilibrium really is and what happens when we medically force it out of balance to save a life.
Definitely something profound to mull over while you're reviewing your notes tonight.
Good luck on the exam, everyone. You've absolutely got this.
Good luck.
And a warm thank you from the Last Minute Lecture team. Thanks for listening to the Deep Dive. We'll see you next time.